Junior Resident, Jubilee Mission Medical College, Thrissur. Today we have a very eminent panel of examiners. As the external examiners, we have Dr. Sureah Pillai, Professor and HOD, Department of ENT, Kasturba Medical College, Manipal, and Dr. Navneet Kumar, Professor, Department of ENT and Head and Neck Surgery, CMC, Ludhiana. As our internal examiners, we have Dr. Sreekuar Pillai, Professor and Head of Surgical Oncology, Jubilee Mission Medical College, and Dr. Ramesh Kumar, Associate Professor, Department of ENT, Jubilee Mission Medical College. At the outset, I would like to thank all the examiners for chairing this session. The total duration for this discussion is 2 hours. The first 90 minutes for the case presentation and discussion, and the final 30 minutes for the examiners in the audience to ask questions and provide any feedback. Shall we start, sir?
Yes,
Yes,
please
yes.
go ahead. Yeah.
Yes, sir. Over to you, sir.
Okay, I think we can start presenting the case. No, Chitra? Shall we proceed, sir?
Yes, please. Yeah.
Yeah, please.
Chitra, please.
Meeting here, all well known. They are on ground floor. Ground floor, there is the
Mute time.
It's a mute.
നമ്മൾ വേണമെങ്കിൽ മ്യൂട്ട് ആക്കി വെക്കാം അല്ലേ? We'll listen to
Hello. Hello, sir.
Chitra, please proceed.
Okay, sir. My patient is Shyamala, 66-year-old housewife, hails from Palakkad, presented to me with complaints of swelling in front of the neck towards left lower part since 1.5 years duration.
Yeah, please continue. We can hear you.
History of present illness. Patient was apparently normal 1.5 years back. Then she incidentally noticed a single small swelling in front of the neck towards left side. She was gradually increasing size over 1.5 years. No history of sudden increasing size. Swelling was not associated with pain, fever, redness. No history of voice change. No history of difficulty in swallowing or breathing. No history of any other similar swelling in the neck. Neither she has symptoms related to hypo or hyperfunctioning of thyroid gland. No history of bone pain, bony swelling, cough with breathlessness, headache. Past history, no history of, she's a known case of bronchial asthma on inhaler. There's no history of hypertension.
Chitra, can you speak louder? It's not very clear.
Hello?
Yes, can you speak louder? Yeah.
There is no history of hypertension, diabetes, tuberculosis, and ischemic heart disease. No history of any surgeries in the neck. No history of radiation exposure in childhood. No history of any chronic drug intake. Personal history, she is
Can you go back? Can you go back to history of presenting complaints? Yeah, you said she had no symptoms related to hypo or hyperfunctioning of the thyroid gland, right?
Yes.
What were the symptoms you looked for? What
Sir,
were the symptoms you asked about?
For hypothyroidism, I asked about tremor, anxiety, irritability, heat intolerance, weight loss in spite of good appetite, diarrhea, for hypothyroidism, I asked about weight gain, and I will look for the facial features and any heat intolerance, constipation.
What happens to the voice? In a case of a hypothyroid patient, what happens to the voice?
There is breathy voice.
Not breathy voice. Why should they get a breathy voice?
Uh,
Their voice will change in a patient with a hypothyroid. So if you're looking for symptoms of hypothyroidism, that's one of the features that stand out.
yes.
Why do you think in terms of, because on your history, you said the patient has presented with the lower neck swelling since say 1.5 years. Why do you think it is only the thyroid swelling? What are the other swellings which can be encountered in the lower aspect of the neck? Because your
Sir,
history is yeah.
Lymph node enlargement can be there,
Which
and
lymph node will come there?
prelaryngeal compartment nodes, pretracheal, paratracheal, and prelaryngeal lymph nodes, subhyoid bursitis, or
Have you
any
ever seen
dermo.
a prelaryngeal node becoming so big that patient is able to notice it as a swelling? They are usually tiny nodes. When you talk about level 6 nodes, usually they are not visible. Even on your clinical examination, even if you talk about, say, a PTC of papillary carcinoma thyroid, you will not be able to really see that. Why would you think of a level 6 lymph node to start off when you say a patient has come with the left side lower neck swelling?
Sir, level 6 lymph nodes, thyroid cancers first metastasis into level 6
That is
lymph
my
nodes.
primary question. Why do you only think about the thyroid swelling? Then you said subhyoid bursitis. Subhyoid would be quite higher up, no?
Yes.
Chitra, anatomically, do you think any other swelling? You just think what are the normal structures there?
Yes.
Probably, yeah, swelling from one of the normal structures.
Swelling, any thyroglossal cyst.
At this age, she is 66 years old, no? You said
Yes.
66, right?
Yes.
He's 66. So this age and location is not in favor of a thyroglossal cyst, would it be?
And anything else which comes to your mind?
It can be lipoma.
Yes.
Okay.
Could be lipoma.
Lipoma.
Any other?
Dermoids.
Okay. Any other soft tissue swelling which you would think of?
Fibroma.
Okay. All that will come as one. Then anything else? Something connected to the lymphatic system?
Sir has already given you half the answer.
Internal examiner, so a little bit of help, yeah.
No, sir, that is fine.
Yeah.
I think we'll proceed, sir. We'll
Yeah,
discuss the
you can
differential
proceed. Yeah.
diagnosis.
Go
Yeah.
ahead.
Yeah.
When you have a patient of, say, thyroid swelling, as Dr. Suresh was asking, one is when you say a patient of hypothyroid with voice change, another you said patient with breathy voice. Now, suppose this patient, you said there is no history of a voice change. Suppose this patient gave history of voice change, and then you say, okay, voice is hoarse or even say breathy. What would be your first suspicion?
First, I will look for any vocal cord palsy.
Okay, so you will think of vocal cord palsy as the first thing, correct? Yes. So, yeah, with the thyroid swelling, when will you have a vocal cord paralysis?
In case if the recurrent laryngeal nerve involvement is there,
No, which
Okay.
pathology is going to cause recurrent laryngeal nerve involvement? That's what sir means.
CA thyroid, carcinoma of thyroid.
Yeah, as a rule, always think, if a patient has presented with thyroid swelling followed by hoarseness of voice, as a rule, you will always consider it as a malignant swelling unless otherwise proved. Even for your exams, even for your practice, always remember, have a very high index of suspicion. A benign lesion of thyroid, even if, it is very big, it is going to be extremely unlikely to cause a vocal cord paralysis when you say, right? Could it be a left-sided supraclavicular lymph node? Because we don't know. You said the patient had a history of lower left-sided neck swelling. That's what you said.
Navneet, we'll do one thing. We'll go with the differential diagnosis. We'll come to all this. Let her finish that history first, okay?
Let her complete the
Yeah.
presentation.
Yeah.
Proceed, Chitra, please.
Personal history, she is consuming mixed diet, good appetite, and unaltered sleep, normal bowel and bladder habits, and no history of any other addictions. She attained menopause 15 years back. Her menstrual cycles were regular. Family history, no history of thyroid disease or any other cancers among family members. Dental examination, patient is conscious, cooperative, and well-oriented to time, place, and person. Fairly built and fairly nourished. There's no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and edema. Vitals are stable. No hand tremors. Palms are soft and moist. There's no eyesight.
Go back to the pulse.
Pulse rate is 88 per minute. Regular rhythm.
What are the things that you can pick out in the pulse in a patient with thyroid disease?
Sir, pulse rate will be irregular in case of hypothyroidism.
No, tell me, you're looking at the pulse. You said pulse is 88 per minute, right? So what are all the things that can affect, factors which can affect the pulse in thyroid disease?
There will be tachycardia.
Tachycardia in which condition? Just explain the condition and the changes in the pulse.
In hypothyroidism, there will be tachycardia.
That is all? Tachycardia?
What about the rhythm? You mentioned it earlier.
Irregular rhythm.
When? Which condition? Irregular meaning?
In thyrotoxicosis, there will be irregular rhythm.
Primary or secondary?
Primary thyrotoxicosis.
Which affects the cardiovascular system more? Primary or secondary?
PDF ಹೇಗೆ ಕನ್ವರ್ಟ್ ಮಾಡೋದು PDF ಕನ್ವರ್ಟ್ ಮಾಡಿದ್ರೆ ಕಮ್ಮಿ ಆಗುದಿಲ್ವಾ ಅದು
Hello?
Hello.
Yeah.
Chitra, be loud, Chitra. Speak into your mic.
Somebody else, please. If you can mute your mic, I think we can listen to Chitra. Some other also has unmuted their mic.
Muted, sir, muted. Yes, sir.
Go ahead, Chitra.
Chitra, കേൾക്കുന്നില്ല. Please check your mic. നേരം കേട്ടിരുന്നല്ലോ.
Go ahead, Chitra.
Hello.
Yeah. Go ahead.
Yes, please continue.
Okay, sir. CNS manifestations are seen in primary thyrotoxicosis. CVS manifestations are seen in secondary thyrotoxicosis.
So what I'm talking about is the pulse rate. There will be ectopics. There will be arrhythmias. Hyperthyroidism, you will be getting higher tachycardia, right?
Because of
So-
hypertension
Yeah, these are the
circulation.
things I wanted you to bring out when you talked about the pulse, okay?
Okay, sir.
Okay, go ahead. Go ahead with your presentation.
Uh,
എന്താ ചിത്രയിലേക്ക് ബ്രേക്ക് എടുക്കണേ ജസ്റ്റ് മൈക്കിന് പ്രോബ്ലം. Chitra, any problem with your mic?
no, sir.
Suddenly, check your mic. What is the problem with the mic?
Hello, sir. Am I audible?
Yes. In between, you are going, unheard.
CVS, CNS respiratory system, and GIT with normal limits. Coming to examination, on inspection, there is an overt swelling measuring approximately 3 into 2 centimeter present on the lower third of anterior surface of neck towards left side. Swelling moves with deglutition. Swelling extending from lower border of cricoid cartilage to 2 centimeter above the medial end of clavicle, and medial margin is in the midline, and lateral margins are up to anterior border of left sternocleidomastoid. Skin over the swelling is normal. There is no visible scar, sinuses, and dilated veins. No visible pulsation. No other swelling in the neck. The swelling extending from lower border of cricoid cartilage to 2 centimeter above the sternal lodge, and medially midline, laterally up to anterior border of the sternocleidomastoid. On palpation, normal temperature and no tenderness. Findings are confirmed, and there is a single overt smooth swelling, regular surface, well-defined margins, firm in consistency, extending from lower border of cricoid cartilage to 2 centimeter above the medial end of clavicle. Medial margin is in the midline, and lateral margins are up to anterior border of left sternocleidomastoid. Skin over the swelling is pinchable, and getting below the swelling is possible. Swelling is freely mobile in horizontal and vertical direction. Rest of the thyroid gland is not palpable. There is no cervical lymphadenopathy. Trachea is in midline. Normal bilateral carotid pulsations. No palpable thrill. Percussion over the manubrium sterna is resonant. There is no abnormal bruit heard on auscultation.
Can you go back? Can you go back to inspection? Yeah. Inspection, swelling moves with deglutition. What does that mean?
Sir, pretracheal fascia encircles the thyroid gland, and it condenses to form Verres ligament and attaches to the cricoid cartilage. So when the cricoid moves during deglutition, thyroid gland also moves.
When the cricoid, what did you say?
Cricoid moves during the deglutition, thyroid also moves.
Why does the cricoid move with deglutition?
Contraction of the inferior constricted muscles.
Okay.
Thyropharyngeus and cricopharyngeus.
Another reason.
Are you sure about that?
You
Does
said some. Sorry.
Yeah, go ahead.
Yeah, you said something about the pretracheal fascia.
Yes.
Yeah, and then you said something about Verres ligament,
Yes.
isn't it?
Yes.
Chitra, something is wrong with your mic.
Hello.
Better.
Okay. Idu madi Chitra. You wear a mic. Whichever mic now you are using, you continue with that. Say just hello. Let's see whether you are speaking.
Hello.
Yes.
Yeah, did you answer? You didn't answer the question. See, one of the most important clinical signs is a thyroid gland will move with deglutition. Do you agree?
Yes, sir.
My question is very simple. Why does it move? You said it is attached to the trachea, right?
Yes, sir.
Why does the trachea move? Why does the cricoid move? It is not because of constriction. Where is the cricopharyngeus attached? You said you were talking about thyropharyngeus and cricopharyngeus, right? Part of the inferior constrictor, isn't it? But what will their contraction do? Does
Contraction.
it pull up the
Right.
cricoid? You understood my question, right? Have you understood? Yeah. Why does the cricoid move up? Which allows the thyroid to move up, which is an important clinical sign. Is there anything above? Go up. The whole larynx moves up, right?
Yes, sir.
Yes. Now, why does the larynx move on deglutition? Do you know? Can you figure it out? Can you think it out? What is attached above?
Thyroid above head.
What is overlying? What is overlying the thyroid? Anterior to the thyroid. What are the what are the group of muscles?
Strap muscle.
Yeah. So what are the strap muscles? You have can you name the strap muscles?
Suprahyoid and infrahyoid strap muscles.
Are
Can
they
you name
called
them?
like that?
Yeah.
Are they classified like that? Or is it a better way of classification? Long straps and short straps?
Long straps and short straps.
Yeah. What are the long straps? What are the short straps?
Long straps are omohyoid,
Long straps.
sternohyoid,
Long straps. Sternohyoid, then
sternohyoid,
thyroid, then short straps.
sternothyroid, thyrohyoid.
Thyroid and omohyoid. Okay, yeah. All right.
Why does the larynx move up with deglutition? What is the principle behind it? What is the physiology behind it? Chitra?
I don't.
Huh? When we swallow, the larynx goes up, right? Yes or no?
Yes.
Hey, Navneet?
Sir,
Yeah, jump in.
no
Where are
problem,
you?
sir.
Chitra?
Yes, it is connected pretracheal fascia.
Who's this? I didn't
Somebody else answered it? Hello? Is it Chitra or somebody else? Please tell us.
So that was someone else. Muted now, sir.
Okay, now it is okay. Others, please mute for some time. When you have the audience time, I think that time you can unmute it. Let Chitra finish it now.
Okay, I think she's getting stuck. All right, go ahead. You continue.
Why would
Navneet, do you want to ask anything?
Yeah. Why would you need to go below the swelling? You know, just come to that examination page. Yeah, you know, you have written getting below the swelling is possible. What do you mean by that? Why would you need to know that?
There is any retrosternal extension.
Okay, you want to rule out any retrosternal extension, and then surgically it will be. So anything else apart from that, would you like to tell us, if suppose a patient has a retrosternal extension of the thyroid gland, what other signs you should be able to elicit?
Sir, Pemberton sign.
Pemberton, very good. Yeah, how will you do that?
Ask the patient to raise the arm above the head and keep it close to ears for some time, and look for the dilated veins over the chest and facial contusion.
Okay, what does it signify? Correct.
It's due to the retrosternal goiter will goes down and obstruct the thoracic inlet.
Goes down.
And obstruct the thoracic inlet.
What does it compress upon?
Great veins.
Which one?
Jugular veins.
No, retrosternally, if it goes, it can compress two veins which form one major vein. What are the two veins and what is the major vein?
Internal jugular vein and brachiocephalic vein.
SPC.
How did you palpate to see whether you could go below the thyroid? How did you palpate? What is the technique?
I palpated the swelling and asked the patient to swallow. Then the swelling moves upwards and I can feel the lower margin.
What was your position when you were examining? And what was the patient's position?
On palpation, I stand at the back side of the patient, and patient in sitting position.
Okay, anything else? Any other instructions you want to give to the patient? Did you give any instructions?
And neck slightly flexed.
Okay. And to turn to any side or
then
be in the...
give my both thumbs over the back of the neck and palpate each lobe with fingers.
Okay, so do you palpate both the lobes simultaneously?
On side, I will ask the patient to turn the head to one side and palpate assess the lobe there, and then goes to other side.
Say it again. Yeah. Suppose in this patient, what did you do? You tell what you have done. If you have done, then you won't need to think.
I ask the patient to turn the head to one side, and I.
Which side?
First left side.
Okay, when she turns to the left side, then which lobe you were palpating?
Left lobe.
If the patient is turning to the left side with the neck flexed, what you said, I'll keep the thumbs and at the back, and then with the fingers, you have got 8 fingers on the neck.
I relaxes the that relaxes the sternocleidomastoid, and I will palpate the fully.
How will you relax sternocleidomastoid? With your fingers. With your fingers, one lobe needs to actually push the other lobe, the one which you are palpating. With your fingers, how will you relax the sternomastoid? And then you feel the other lobe. And similarly, the opposite side.
There is Lahey's method also. For palpation of each lobe, there is Lahey's method also. In Lahey's method, Examiner will push the lobe from one side and palpate the lobe with
Okay.
the other hand.
What is Kryle's method?
Place thumb over the swelling and palpate for any nodules.
Do you know who Kryle was? Have you heard of Kryle? In any other respect?
What did
Neck dissection.
Kryle describe? Something related to oral malignancy?
I think Dr. Sreekuar will be very familiar with this.
I'm sorry?
You will be very familiar with Kryle and his
Yeah,
techniques. Yeah.
Yeah.
So
Yeah,
you look at his specialty and then you'll be able to answer.
Incision of neck dissection.
Correct.
Yeah. Yes.
George Kryle in the year 1908.
All
So
right.
why do you need to examine in this way? What are you trying to look for? Say this patient has already given you the history that, this patient has this swelling over the left side of thyroid gland, as we assumed. So why would you need to do all that? Okay, lower border understood, but then why examining all these things in detail? What additional information you want?
I want to exclude the retrosternal
Okay, that
extension.
you excluded by saying that swelling is moving with deglutition, and then I am able to easily go to the lower border.
Then to exclude the malignancy.
How will you do that?
Skin over the swelling is pinchable. That is
Okay.
not fixed to skin, and swelling is freely mobile in horizontal and vertical direction.
All right. If suppose a skin is not pinchable, then what will you interpret it as?
Swelling is fixed to skin.
Yeah. So which malignancy of the thyroid gland will usually behave this way?
Papillary carcinoma.
Papillary carcinoma, this patient can have. Papillary carcinomas could be very anaplastic.
Anaplastic carcinoma.
Anaplastic would be very fast growing and then carries a very poor prognosis. If you have a fixed thyroid swelling, you should also, then they will give you a history where they will say that, it is rapidly increasing in size. So there are a lot of red flag signs associated with anaplastic carcinoma. All right. How will you rule out, you said normal bilateral carotid pulsations. If you are not able to feel them on the left side, okay, not really in this patient has a small thyroid swelling, but otherwise you want to rule out if there is anything which is adhered to that, right?
Yes.
So suppose this patient, pardon, go ahead.
Yeah.
The carotid pulsation is not palpable, it's very sign positive.
Yeah, so now if you have a patient with, say, left-sided lower neck swelling, which is bigger than this, you assume, and then that patient did not have the carotid pulsations where you could not feel that because of the swelling, bulk of the swelling, and you feel, how will you know that, it has encased or it has encroached upon the vessel? Clinically, are there any signs which can give you clue? Of course, you will need to do a good imaging, which will give you some clue that, this may not really be involving the vessel. You understood my question? If you have this patient's swelling, which is over the carotid area, right? Till here, you understood?
Okay.
You are not able to feel the pulsations of the common carotid artery. How will you rule out on your clinical examination whether it is adherent to the vessel or it is just over the vessel and not adherent to that, and the flow in the vessel is normal? There is a hint in this question.
What is the continuation of the carotid? It continues
I will look for any In the bruit.
No.
How will you look for the bruise when you are not able to feel the carotid pulsation? No. How will you feel the bruise there? There is a hard swelling which is overlying that area. Sir is asking, no, how does it travel? How is the normal course up when it goes up superior?
In front of the pinna, which vessel do you feel for?
Superior, superficial temporal artery.
Okay.
So if you have those pulsations, then
there is no compression.
yeah,
Then
no,
there
no
is no
engagement.
infiltration.
No
infiltration.
engagement of infiltration.
Yeah. See, Chitra, it just goes to say that the vessel is not infiltrated. Probably the vessel is displaced.
Yes.
Understood?
Yes.
Yeah.
Okay, go ahead.
Okay. Yeah.
Did this patient have pain? Any pain?
No.
No, sir.
No. Do you know any conditions in thyroid swelling which will produce pain over the thyroid?
Sir, in thyroiditis, inflammatory thyroiditis will produce pain.
Then what are the
then
other conditions which will produce
any
pain?
hemorrhage into the nodule will also produce pain.
Hemorrhage, then
Anaplastic carcinoma,
malignancies.
malignancy,
Malignancies
especially
will produce.
anaplastic carcinoma.
Okay, all right, go ahead. Finish off the rest of the presentation.
Examination of oral cavity and oropharynx, mouth opening adequate, limbs, gingivo-buccal sulcus, gingivo-labial sulcus, gums, teeth, floor of mouth, tongue normal, retromolar trigone, palate, anterior pillars, uvula, posterior pillars, posterior pharyngeal wall also normal. Indirect laryngoscopy, base of tongue normal, glossoepiglottic fold, vallecula, epiglottis, pharyngoepiglottic folds, piriform fossa, arytenoids, aryepiglottic folds normal, vocal cords, both vocal cords normal and equally mobile.
Why is it important to note the mobility of the vocal cord?
In case of recurrent laryngeal nerve involvement, vocal cord palsy will be there.
So you want to know about the status of the vocal cords at this stage, right? So you want to look at the mobility. You're worried about the recurrent laryngeal nerve, right? Okay, all right. Go ahead.
Examination of ear, pinna, external auditory canal, tympanic membrane normal, tuning fork test all normal. Examination of nose, external framework of nose normal, vestibule normal, anterior rhinoscopy normal, functional test were normal. Summary.
Can you have hearing loss with the thyroid problems? Any condition?
Yes, sir. Hypothyroidism. In case of hypothyroidism, hearing loss, tinnitus, and will be there.
Anything else? So fine. Anyway, yeah. Go ahead. Finish your case.
Summary. My patient is a 66-year-old, clinically euthyroid female, presented with 3 to 2 centimeter sized paleness solitary nodule in left lobe of thyroid for past 1.5 years. There is no cervical lymphadenopathy and no compression features. My diagnosis is left solitary nodule thyroid and patient is clinically in euthyroid state.
Just show the previous slide. Fine. Okay.
Okay, so your diagnosis is, do you have any other differential diagnosis other than this?
Sir, it can be a thyroid adenoma or thyroid cyst or dominant.
Go to the next slide. Go to the next slide.
Chitra, anything other than thyroid?
Go down.
Go to the last slide.
Yeah.
Yeah. Okay. Any other differential diagnosis? Any idea? Do you have a this thing? If it was a malignant thyroid, do you have a TNM staging?
Yes, sir. AJCC TNM stage.
Supposing this was malignant. We don't know. You have not gone into the investigation yet. You've made a clinical diagnosis, right? 56-year-old lady. So if it is malignant, what would be the T stage?
T3.
2 centimeters. 2.
Why do you say T3? Look at the size.
T3 പറഞ്ഞ.
T2.
What is T3?
T3. Swelling 2 to 4 centimeter size.
You said it is 3 into 2, no? The size. Hello. You said
Yes.
3 into 2. So it falls in
T2. T3 is more than 4 centimeter.
Right.
Okay. What are the investigations you want to do?
Sir, first I will check the TSH. If the TSH is on lower side, I will go for technetium 99 per technique scan. Or if it is normal or higher, then I will go for ultrasound neck.
No, why would you need to do a thyroid scan? Can you just say what you said? If the TSH is low, then you will get a thyroid scan, is it?
Yes.
What is there in your mind when you do a thyroid scan for this patient? And then why would you, because yeah, it's a baseline. When you say the workup, it is always a good idea to do a free T3 and T4 also along with TSH. You know, TSH will give you some idea, okay, if it is hyper or hypo, but then that could be subclinical. You know, a lot of normal females, middle-aged females might have a little elevated TSH, but then T3, T4 would be normal. Yeah, why would you go for the scan?
For any toxic thyroid nodule or hypofunctioning nodule.
What is a more relevant investigation than a thyroid scan? You said which scan did you want to do?
Technetium.
Technetium. Why do you want to do a technetium scan when there are other imaging modalities available which will give you more information?
And I think Chitra, what I understood was she is saying that if the TSH is low, then she would think of toxicosis and she would do some kind of
But she didn't mention the T3, T4 levels, as Navneet was mentioning. Even though TSH is low, T3 and T4 can be normal. She has mentioned that TSH will be low and she will go for a technetium scan. Would you want to do that, Chitra?
According to recent ATA guidelines, I read like that.
Which among the imaging modalities, which will give you a maximum information now that what we're using?
Ultrasound neck.
Yes.
Yeah,
Is
that's
there-
a cheap and a readily available test, and then gives you a lot of information. In fact, a lot of people would prefer ultrasound over. Even in our center, we hardly get any other investigations done as far as the imaging is concerned. Ultrasound gives you a lot of information, and as long as you have a good radiologist who is reporting. Yeah, please go ahead, as Dr. Suresh is asking. Yeah.
Yeah, so ultrasound will give you, as Navneet was saying, give you a lot of information. What is the Thyroid scoring? What does Thyroid mean?
Thyroid imaging and reporting data system. It classified the thyroid nodule into highly suspicious, intermediate suspicious, low suspicious, and very low suspicious, and benign. If thyroid is 0, it's benign. If it is 1,
Thyroid 0 is what?
Benign.
Then what is thyroid 1?
Non-diagnostic.
Hello? Yeah.
You just repeat the classification thyroids again, so you will know it.
Highly suspicious.
No, T0, T0. Start with T0. Sorry, thyroid 0. not T0.
Yeah.
Non-diagnostic.
Yes.
Benign.
What does that mean? Non-diagnostic.
We have to further investigate it.
No. Yeah. Go ahead.
Then benign, very low suspicious, intermediate suspicious, high suspicious.
Can you tell the features, when you say, what are they, why are they saying this is benign? Why are they saying this is suspicious? Why are they saying it is highly suspicious? What is atypia of, there are some categories when you say that, if you talk about, say, thyroids 2, thyroids 3, thyroids 4, like that, it will become easy for you to explain, as well as for people who are sitting to understand what is, what are you trying to convey. So when you say thyroids 2, say it's a benign lesion, most likely, what are the features the radiologist would have seen in the ultrasound?
For benign lesions, isoechoic, iso or hyperechoic, cystic
Chitra.
nodule.
Chitra,
Echogenicity, right? You're talking about echogenicity.
Chitra, what are the components of a thyroid? What are the components which you look in a thyroid imaging?
Component, shape, margins, echogenicity,
Okay.
and echogenic foci,
And composition.
composition.
Okay. Yeah. All right. These are the 5 components that you look in a thyroid. All right. So above which thyroid score would you suspect malignancy? Or above which thyroid score would you be more concerned?
3.
3 and above. Okay. Please go ahead.
Yeah, so what are the other features? You said it could be hyperechoic. Okay. What else would point more towards a benign pathology?
Cystic swelling, hyperechoic, wider than taller. Then microcalcifications are more point towards benign pathology.
Okay. When will you start suspecting it is malignancy?
For malignancy, hypoechoic, taller than wider, solid nodule. There is punctate echogenic foci. Microcalcification.
Microcalcification. Anything else? Anything to do with the vascularity?
Vascularity is not included in thyroids.
Okay, but then I'm just asking in general, if there is any
There is
otherwise,
vascularity.
yeah,
Vascularity.
increased peripheral
Central
vascularity, the
vascularity.
breach of the capsule, infiltration of the straps, all those things will also be kind of raising a suspicion that this could be malignant. Okay.
Yeah, Chitra, I have a question for you. You said that in a thyroids, vascularity is not a component, but you said vascularity is something which you normally look for in a typical of a primary, isn't it?
Carcinoma. Yes.
So this is normally thyroid denotes which kind of carcinoma thyroid? Thyroid is more
papillary carcinoma.
Okay, good.
Have you heard of a comet tail appearance
Yes,
in
sir. It
ultrasound?
points to benign nodules.
More of a benign read. Why
Benign
does it?
nodules.
Why is it in the shape of a comet? Do you know? Why is it
Don't know.
called comet tail appearance? No.
Don't know.
Okay. Now, what other information can you pick up from a ultrasound? You have a thyroid scoring. Then what about nodules? Size of nodules?
Based on the thyroid scoring, I can categorize the nodule and I get an idea about whether it is point towards the benign or malignant. And I can, based on its findings, I will go for FNAC.
So what would make you point towards an FNAC from the nodules? Size of the nodules. If you have a 5 millimeter nodule on ultrasound or 8 millimeters, let us say 8 millimeters. Would you want to do an FNAC? What is your criteria for doing an FNAC from a nodule after ultrasound?
It is highly and intermediate suspicious nodule, even more than less than 1 centimeter nodule, you will go for FNAC.
Less than?
0.5 centimeter.
1 centimeter.
You would want to. If it is more than 1 centimeter, you don't want an FNAC.
No, I think what she means is if it is causing high suspicion, even if it is less than 1 centimeter, she will go. Is that what you meant?
So what do you
What
mean
are
by
those
high?
cause-
Yeah, high suspicion then. You're saying less than 1 centimeter, high suspicion, you'll do FNAC?
Less than 1 centimeter, even if it is less than 1 centimeter, we have to go for more than 1 centimeter, we will do FNAC for high and intermediate suspicious. But in certain cases, even if it is less than 1 centimeter,
So what are those certain cases you're talking about where you want to do an FNAC?
Essentially, what are the high risk groups? High risk groups.
previous radiation exposure or the family history of any malignancy or a child coming with a solitary nodule
Right.
or any pet incidentaloma like that.
Any syndromes associated with?
Yes, sir. Medullary for medullary carcinoma.
No. Any syndromes associated with well-differentiated carcinoma?
Werner syndrome
Okay.
associated with papillary.
Okay. Then
Just
just rattle off of the name of a few syndrome and we'll go into the
Cowden
next.
syndrome.
Okay.
Familial adenomatous polyposis, Gardner syndrome.
Not Gardner's.
Gardner syndrome.
Okay.
Pendred syndrome.
Pendred will not have. Okay, doesn't matter.
What do you mean by FNAC?
Fine needle aspiration cytology.
How fine is the needle?
23 gauge needle.
How do you do an FNAC? If I were to give you a thyroid swelling, how will you proceed to do a
in
good
this patient
FNAC?
only. Yeah, in this
Yeah.
patient only, how are you going to do?
23 gauge needle and 10 cc syringe. First I will.
You're a right-handed person.
So he's telling you to do something with the left hand.
Patient in sitting position and I will fix the nodule with the left hand.
Right.
And I will insert the needle into the nodule and apply suction. By maintaining the suction, there are 6 passes in radial manner.
So you will put the needle in and apply suction.
Insert the needle and move in and out.
Right.
No, when do you said something about suctioning?
Nothing, sir.
You said you will put the needle in and you will suction. Is that correct?
Non-aspiration cytology.
Chitra?
അല്ല suction ഇട്ടിട്ടാണ് active suction ഇട്ടില്ല. Just ഇങ്ങനെ.
Are you there? I think we lost communication or?
Yeah.
Chitra.
I'm able to hear, sir.
Yeah.
Oh, you were thinking. Okay.
Yeah.
Have you done an FNAC? Yes or no? Have you done it in your? Huh?
No, sir.
No.
Oh my God.
No, because this technique is important. Otherwise, the yield will be less, and then we'll be in trouble when the report comes from the pathologist.
Would you like to go for an ultrasound guided FNAC, or as you said, I'll just hold the nodule and put the needle in? And if yes, why? Or if no, also, what is the rationale for that?
An ultrasound guided FNAC provides has more diagnostic accuracy.
Yeah, what are you going to do,
Especially-
and what is there in your mind? Yeah, it actually
Especially
different
for,
institutes have different protocols. Yeah, okay, go ahead. Yeah,
especially for small nodules, not well palpable.
okay. In this patient, you have a visible nodule. Will you go for ultrasound guidance, or you can just put in the needle and then
FNAC.
will you use ultrasound as your guide, or you don't think it is required? Both the ways have their own pros and cons. Which one will you use and why? Say it.
In this case, the nodule is palpable. So
Thyroid gland is actually, it can have a mixed solid and a cystic component. So again, see, when you have different institutions will have different practices and protocols, and no one is wrong in that. But we always, as a rule, try to do an ultrasound guided FNAC from the thyroid gland, because usually what happens, if you are just aspirating and then a cystic component kind of tells you a benign report, you plan the patient for, say, this patient for a left side hemithyroidectomy, and then the final report comes as a papillary thyroid carcinoma, then patient will again be subjected for another revision. So it is, in my understanding, it is always better. But then again, as I said, it is a personal preference rather than something which is mandatory or a written rule. So that is my understanding about it. So sir is also very senior, so what he feels. But usually,
No, what we do, Navneet, here also is ultrasound guided, but as a postgraduate,
do.
as a resident, you are expected to know how it is done.
No, sir, our
And
residents
you-
actually go, the radiology team will be doing the ultrasound, and then they assist in them in procedure in the thyroids. Yeah, because they will be able to exactly tell which is the solid component in that. So 100% of the patients will have ultrasound guided FNAC, as far as, even if someone gets an outside report, and then if it is not done, we subject them to, and then sometimes there are changes in the final reports of FNA, and yield is good. You don't say that this non-diagnostic, as we were just discussing.
Chitra, going back, one of the things, are you there?
Sir.
Yeah, one of the things you should not do is aspirate. I mean, aspirate means you should not get the blood back into the syringe. Why? When you're doing an FNAC, you put the needle in. I agree with you, you make multiple passes. But what happens if you pull the plunger? What happens?
There is
Where do the cells
aspiration.
go? Where do you want to keep your cells? Should it be in the piston, in the syringe, or should it be in the needle?
What is the name of the procedure?
Fine needle aspiration biopsy.
Okay, you're getting, I think she's getting confused. Have you heard of FNNAC? Have you heard
Fine
of that?
needle
term?
non-aspiration biopsy.
Yes. Can it be done for thyroids?
Yes.
Have they described it for thyroids? You've heard of it, right? Are you
Chitra,
there?
Chitra, check your mic.
Yeah, because she disappears sometimes. I don't know whether she's there or not. Yeah, fine needle, non-aspiration
There was
cytology.
some problem with the connection.
Oh, okay. I think she's in a library, is it?
Sir, I can hear.
Yeah, what does that mean? Fine
There's
needle,
my-
non-aspiration cytology,
Sir, I
FNNAC.
can hear.
And why is it useful in thyroids?
Chitra, what is the difference between fine needle aspiration cytology and fine needle non-aspiration cytology? The answer is in the question itself.
I don't think
Can you hear me,
she's
Chitra?
not familiar, I think. I think we'll move on.
Chitra കേൾക്കുന്നുണ്ടോ?
Sir, കേൾക്കുന്നുണ്ട്.
She's thinking. Okay, if you don't know the
Fine.
answer, it's all, huh? Do you know?
Don't know.
Okay, we'll move on. So you are talked about thyroid scoring, FNAC. What is the scoring system for FNAC?
Bethesda.
Yeah. What is Bethesda classification? What is it based on?
What did
but-
Bethesda? Where did it take its name from? What is this Bethesda? Is it name of a person or
Emotion connection.
Don't know.
you find out? This is a homework for you.
Yeah.
Bethesda. What it's all? These are all interconnecting things and quite interesting. You know what had happened, how the things were. You find out Bethesda. You know, just put it in Google. Also, you will be able to see. Okay. Yeah. Continue as sir had asked.
Okay,
Bethesda
how much time? We have only some 20 minutes left, right? I think. Yeah, so what are any
10
other
minutes
relevant
left.
investigations you want to do? You've talked about ultrasound. You've talked about FNAC. Anything else? You said TSH, right?
Yes.
Yeah. Then anything else? You're happy with this? You can make a plan in this case?
Sir, in
Is a
T3,
CT scan relevant? Would you want a CT scan in this patient?
no.
Why?
If there is any T4A or T4B disease or any retrosternal extension, mediastinal extension, or any large lymph node involvement, these cases, we will go for CT scan.
Okay, all right. So how will you go
Ultrasound
to-
is actually a lot of, it's quite dependent on the person who is doing. So again, if you have the same person doing the repeated ultrasounds, the yield would be much better as compared to someone who had just started doing head neck and they are maybe more focused on the abdominals and all. I mean, but then it is more sensitive as compared to the CT. Yeah, proceed.
Right. Okay.
Okay, what is the plan? You're saying euthyroid, you're thinking of a benign condition, right?
Yes.
Yeah, what is your plan?
I will go for surgery.
It's a benign solitary nodule, euthyroid, correct? What is the indication for surgery in this?
I will go for surgery after this USG and FN, based on these findings, USG and FNAC findings.
Both USG and FNA are pointing towards a benign condition. What is the role of surgery in this patient?
For benign condition, if it
Why do you
is,
want to operate on this patient?
if there is any pressure symptoms?
She doesn't have pressure symptoms.
Pressure symptoms.
He doesn't have any complaint. She just says that, there is just a small lump and then it has been just sitting there. She may not be much concerned about that. There are no pressure symptoms. There are no red flag signs. The ultrasound, FNAC, they're all suggestive of a benign pathology. What is the need for surgery? She might have some cardiac
If there is any
issues.
cosmetic problem, if there is any
Cosmetic
cosmetic
is one,
problem,
yeah. If patient wants, okay, then yeah. Cosmetic would be one issue here.
But what would you advise? The patient is in front of you. What is your opinion?
better to observe the swelling by serial ultrasound scan, and if there is any malignant change, we can go for surgery.
So you're going to keep her on regular follow-up.
Yes.
No pressure symptoms. The patient is euthyroid. No significant evidence for malignancy. You'll keep on follow-up. But the only indication for surgery in this case is if the patient wants it out because of cosmetic reasons, right? Yes. But for cosmetic reasons, if you do it, you are going to give a scar. And there may be a chance of recurrent laryngeal nerve injury, right? What is the incidence of recurrent laryngeal nerve injury in thyroid surgery? If somebody comes to you, the lady is coming to you, she wants surgery, but she's very worried about this nerve injury. What are you going to tell her?
Incidence is very low, only 2 to 5%.
Incidence is low, around 2%, right? You said 2 to 5%.
Yes.
Okay, so
But
what's
chances are there.
Yeah?
But chances of recurrent laryngeal nerve palsy is there. So if you are more concerned with these things, don't go for surgery.
What surgery? Okay, if the patient is ready for surgery and you're ready to do the surgery for cosmetic purpose, what surgery would you do?
Hemithyroidectomy.
What thyroidectomy?
Hemithyroidectomy.
Hemithyroid. What do you mean by a hemithyroidectomy?
Removal of one lobe and isthmus.
Why do you want to remove the isthmus if the disease is confined to one lobe? Why do you want to do a hemithyroidectomy versus a lobectomy? You have to justify all these things to the patient. You're in Kerala, right? They're all well read. They'll be reading up all the statistics. Lobectomy versus hemithyroidectomy. Why do you want to remove the isthmus? You can justify. I'm not saying you're wrong or right. You have to justify. Are you there?
Chitra കേൾക്കുന്നുണ്ടോ?
കേൾക്കുന്നുണ്ട് sir.
Yeah, yeah. So why would you do isthmusectomy? Isthmus covers what?
Trachea.
Trachea.
So what is the
To remove
advantage
the
in
pressure
removing?
over the trachea.
Are you thinking or you want to move on?
Yeah, I think
Sir,
Dr.
to remove
Suresh
the
should,
pressure over the trachea.
I think Dr. Suresh, you could tell her the answer because she's unsure, I suppose so.
Most of the times when they remove one lobe, if you don't remove the isthmus, it will undergo hypertrophy and cover it and cause, they say, theoretically, tracheal compression. So it's more of an advantage to remove one lobe along with the isthmus so that the trachea is freed.
Yeah, it's
Because there
always,
is-
again, yeah, hemithyroidectomy is usually recommended. Yeah, lobectomy. Yeah.
Hemithyroidectomy is usually an accepted protocol for this.
Yeah.
But I wanted you to justify, do you do a lobectomy? Do you do a hemithyroid? And what are the advantages? What incision would you make? Where would you make an incision for hemithyroidectomy?
Focus incision.
What is Coker's incision?
2 centimeter above the suprasternal notch, over the skin crease, horizontal incision.
Who was Coker?
Uh,
I say Kocher,
Uh,
Kocher.
Father of thyroid surgery.
Why do you
Theodor
call him
Kocher.
the father of thyroid surgery?
He first
Why?
did.
What's his contribution? The incision is named after him. There are instruments named after him. There's a test named after him. You know the test, Kocher's test?
Yes.
Okay.
Yeah, tell us what it is.
Push both lobes of thyroid will cause compression over the trachea and stridor.
What is that called as? What kind of trachea?
Scabbard trachea.
Right.
Number test, yeah. He's
Right.
won a Nobel Prize for his work on thyroid.
Theodor Kocher, German, student of Bill Roth.
Yeah,
Okay.
Bill Roth is famous.
Yeah. So he's
Bill Roth.
described thyroid incision, Kocher's forceps, Kocher's subcostal incision for cholecystectomy, Kocherization of the duodenum. All right.
If you want to read up on thyroid, you have to read up on his history. Okay. How will you find the recurrent laryngeal nerve?
In the trachea
What are your
esophageal
techniques to identify the recurrent laryngeal nerve?
Most commonly, it identified the Bayes triangle,
What is that?
bounded by the common carotid artery laterally and above inferior thyroid artery, and recurrent laryngeal nerve itself is the medial boundary.
So
How
it
will
is
you
not, it
identify
is not found in a triangle, isn't it?
this? Yeah,
Yeah.
This is a misnomer.
it's a part
Yeah.
of the
Yes.
triangle actually. How will you
Part of the
identify how will you identify inferior thyroid artery while doing the thyroid surgery?
Thyroid artery.
There are going to be so many vessels, you know, when you explore the thyroid gland. How will you identify?
Coming from below
From where?
and supply the entire lower pole.
No, you can imagine, you know, you have given the incision, raised the flaps, retracted the straps, exposed the thyroid gland. Now, this area, where are you going to see the inferior thyroid artery? With this vessel has come, this is inferior thyroid artery because of these characteristics.
Hello.
Okay, inferior thyroid artery is a branch from
Thyrocervical tract.
correct thyrocervical trunk. So how is it going to go towards this triangle?
Yeah.
Moves upwards and
Correct.
goes to a lower pole. Towards
No,
the lower.
no, Chitra, that was not the question. Thyrocervical trunk is a branch of the subclavian artery. All right, first part of subclavian. It goes up and then it goes posterior to what? Which vessel?
Which is the major vessel sitting there in your field?
Major artery in the neck. Medial to the jugular
Common
vein. Common
carotid artery.
So this is the only vessel which will be actually coming from the area, as sir has mentioned, coming from the area which is going to be posterior to the common carotid artery. It's a big help when you are seeing this vessel. Now, okay, so if you have identified this vessel, you know, and then say, how will you avoid bleeding from this vessel? Where are you going to ligate or clip or coagulate this vessel?
Close to the gland.
Why? What do you mean by close to the gland?
Because it is the major supply of parathyroids.
Okay.
So, preserve the blood supply to the parathyroids.
Correct. So what is your understanding about close? What do you mean by close? How close?
Close to the capsule.
It is the tertiary branches of the inferior thyroid artery which you will be clipping. Individual branches you will be ligating. Which parathyroid is supplied by inferior thyroid artery?
Inferior parathyroid.
Right.
What is the blood supply of the superior parathyroid?
Superior, yeah. What about superior?
Ascending branch of posterior branch of the superior thyroid artery.
What percentage of superior thyroid is supplied by the superior parathyroid gland is supplied by the inferior thyroid artery? It has a major component in supply.
My major component is from the inferior thyroid artery.
Yes.
Only lesser contribution from the posterior branch of superior thyroid artery.
So that means inferior thyroid artery is actually supplying both the parathyroids. So you cannot just afford to clip the main vessel. That is number one. Then you need to really identify the main trunk and then go for the bifurcation and then eventually clip it right over the gland. You know, then it is a subcapsular dissection, which is usually recommended for the benign lesions. There you are going to ligate each and every vessel, small tiny twigs you are going to be coagulating to save the parathyroids. Yeah. How will you identify parathyroids then? So you were asking something.
No, you go ahead. You finish yours, then I'll ask.
Parathyroid is tan caramel color and is soft, and there is a muscular hilum and is movable.
Where will be the location when you say parathyroids?
Superior parathyroid is posterolateral to posterior pole, just lateral to sucrocandal tubercle. Inferior parathyroid is
Tubercle of Zuckerkandl. What is that?
it is the fusion of the ultimobranchial body, thickening due to the fusion of ultimobranchial body with the medial enlarge.
So how does it help you?
What's the relationship?
Superior parathyroid is just posterior to the sucrocandal tubercle.
Okay, recurrent laryngeal nerve. How many branches are there? As you trace
Usually
it up.
2 branches, 2
What-
extra branches, ascending and descending.
Ascending and descending, or anterior, posterior.
Anterior, posterior.
Which is
Anterior
more
and
important? Which is more important to preserve, anterior or posterior?
And anterior.
Why?
Anterior is motor and posterior is sensory.
Where does the posterior branch go? Towards where?
Subglottic region.
For sure? Okay, why is it called recurrent laryngeal nerve?
Because during embryology,
Why is it called? Forget embryology. Why is it recurrent?
Current.
it goes down and again recurs back to the neck upwards.
Have you heard of non-recurrent laryngeal nerves?
Yes.
What is the
It's more
percentage
common
of
on the-
non? What is the percentage of?
0.8%,
Huh?
0.2 to 0.8%, and it is due to the retroesophageal subclavian aberrant right subclavian artery. Sometimes the right subclavian artery arises from the arch of aorta and it goes posteriorly in the left side.
Okay, if the recurrent laryngeal nerve is injured during surgery, unilaterally, what will be the position of the vocal cord?
Vocal cord will come in paramedian position.
Why is it in the paramedian position? What are the different positions of the vocal cord?
Median, paramedian,
Now there is one muscle which is
cadaveric position.
responsible to pull the vocal cord into the midline, paramedian.
Abductor.
Abductor palsy.
And which is a muscle supplied by superior laryngeal nerve.
Cricothyroid muscle.
Yes.
So, what is the function of the cricothyroid muscle?
Mainly adduction.
Now, what does cricothyroid do to the vocal cord?
In intact physiology, what is the function of the cricothyroid? Means both nerves are.
Tenses the vocal cord.
Tensor the vocal cord, correct. Whenever something gets tense, it becomes elongated, it becomes thin also. All right.
All right. Now, this patient you said was interested, you were doing it for cosmetic surgery. Is there any other way you can approach this thyroid without making an incision on the neck?
There is transoral thyroidectomy.
Transoral thyroidectomy.
Before
How
that.
will you- Yeah.
Okay, trans.
Transaxillary thyroidectomy.
What?
Transaxillary, correct.
How will you approach the thyroid from the axilla? Yeah, go ahead. You're right. Where do they develop all this? Transaxillary approaches. Which country?
Don't
Taiwan,
You don't know.
know, sir.
Korea. Oral.
Have you heard of robotic surgery for thyroid?
I'm not talking.
Yes.
What are the indications?
Endoscopy, transaxillary, Taiwan,
Less than 3 centimeter. Not even robotic surgery.
Chitra?
For cosmetic purpose.
That is obvious. For cosmetic purpose, you don't want an
Small
incision on the neck.
For small nodules.
Question then. Sir, can you repeat the question?
Indication of robotic
Yeah,
surgery.
indications for transaxillary robotic surgery. When do you do it? That is why she was saying cosmetic. So I said it is obvious. There is no incision, so it is cosmetic. But other indications with regard to the thyroid. Can you do it in malignancies? Can you do it when there are lymph nodes, metastatic lymph nodes?
Even larger ones.
Don't know about it, sir.
You don't know about it. They'll ask something regarding all this. Huh? If you have a malignancy in the thyroid, papillary carcinoma, which is the most important level that you want to clear? Papillary
Central
carcinoma.
compartment.
Which one?
Central compartment.
What is central compartment?
Bounded by hyoid bone above, suprasternal notch below, and 2 carotids laterally.
And 2 carotid.
Carotids.
Carotid.
Actually, it is not the suprasternal notch. It said that innominates below, hyoid above, and carotids laterally. Okay.
Lateral.
What are the other vessels which can get involved in papillary thyroid? What is the other pattern? Level 6, correct. What other
First
pattern?
level 6, then level 3, then level 4, level
Right.
2,
Right.
5.
Yeah, 5. Yeah, it goes that, 1A, 1B would be rarely involved in that.
Really important.
Yeah. Okay.
If there are no lateral lymph nodes, level say 2, 3, 4, or 5, would you like to do a neck dissection there? In a case of papillary carcinoma, is it
Only
indicated?
central compartment clearance.
Only central compartment clearance.
Compartment
If there are no nodes in the central compartment, would you like to do a central compartment clearance? Is it indicated?
No, prophylactic central compartment clearance is not indicated.
Why? In a papillary carcinoma, which is not histologically aggressive, without any lymph nodes in the central compartment, would you do central compartment clearance? You said no. Why? Why don't you want to do it?
Only done in aggressive, not aggressive.
What do you mean by aggressive histology in papillary carcinoma?
Dorsal variant, column, insular variant, hobnail, diffuse sclerosing, serous.
So
So
why
if
is it that you
patient
don't
has-
want to?
If you
Yeah.
do,
Yeah, go ahead. Yeah.
Chitra, if you do a prophylactic central compartment dissection in the absence of clinical or ultrasound proven, there are no lymph nodes. What are the 2 structures that you can injure? One is already said, there are only two structures which you can injure. What are the two structures?
Common carotid.
Not common carotid. When the central compartment is dissected.
Innominate.
No, you wouldn't. You have to be a very bad surgeon to do that. Yeah.
Recurrent laryngeal nerve.
Recurrent laryngeal nerve. And second, the yellow tan
Here
gray
only, na?
structures.
Yeah, it's looking like a
Parathyroid.
lymphatic. Parathyroid. Yeah, so two
All
structures.
right. Yeah. So however brilliant a surgeon you are, at least 20% chance of temporary hypocalcemia.
Yes.
However brilliant a surgeon you are. So don't fiddle with the central compartment unnecessarily. Right?
Unless it is required, yes.
Correct.
If this patient has a papillary thyroid carcinoma with pulmonary metastasis, then what will be your treatment protocol?
Then I will go for first total thyroidectomy.
But usually in head neck, we say if you have, suppose this patient, you have say a malignancy of tongue with pulmonary metastasis, would you go for a glossectomy, partial or hemi, or? When you have a disease with distant mets, will you be operating on the primary site? First answer that, then we will come to this. You're not sure. What about, okay, you stick on to what you were saying and justify. You will go with what?
Total thyroidectomy.
Okay.
Followed by?
Then I will assess the risk, categorize the patient based on the risk stratification.
No, doctor has said that the patient has got pulmonary metastasis.
Then I will go for radio ablation and external beam radiotherapy.
Both?
No, you wouldn't go for both.
You want to do both?
No,
These are well differentiated
radio.
carcinomas. No, yeah, well different. PTC.
Radio ablation, radioactive ablation.
Radioiodine ablation we will choose. Okay.
When do you do this radioiodine ablation?
If there is extensive extra thyroidal extension or large lymph node involved, large lymph node, presence of a large lymph node, in one stage.
Okay, following surgery, when would you like to do it? Timing?
After 4 to 6 weeks.
Why do you want to wait so
What is
long?
what is the reason for that?
The target, to achieve the target TSH more than 30 milligram per deciliter.
Not milligram. How would you achieve your target TSH? What are the methods?
TSH suppression.
No. What are the methods by which you would achieve your target TSH?
You want the TSH to reduce or you want the TSH to increase
Stop the
in this?
thyroxine. If the patient is not tolerating, then go for recombinant TSH or oral T3 tablets.
Okay.
Sir,
Right.
may I interrupt now?
Yeah.
Audience are eagerly waiting. They
Okay,
are
yeah,
requesting
please.
this.
We will stop.
Yeah.
Yeah.
Okay.
Yeah.
Yes, audience, please can come in and you can ask your questions.
Yeah. How would you rate Chitra, both of you?
No, she's prepared very well.
Yes.
She's
Practically
clinical
sound, yes.
science here and there. I think she has to be a little bit more confident in trying to justify her answers.
Yes.
But otherwise, she has done very. Which year is she in? Is she final year or second year?
Chitra, which
Sir,
year are
actually,
you?
I'm just into final year. I'm not the exam going.
Okay, all right, understood.
No, for that actually your presentation was very good.
Yeah.
You read well. Theoretically, you had read well. So clinically, maybe once you come in practice, these things keep getting refined. You keep reading more and more literature in whichever surgery you are interested in. You did well. Easy pass.
Thank you, sir.
Yeah. Yeah, I think you can proceed with the other questions now. Yeah.
Yeah, you can. Audience wanted to come in, please join us. From Trivandrum, yeah. Somebody asked. Hello?
We have many professors in the audience. So can you please, Satish sir?
Question.
Sir, proper answer for why thyroid and the larynx moves during deglutition.
Hello? Can you repeat the question, please?
Sir, actually, the proper answer
No.
why thyroid and larynx moves during deglutition.
Yeah, that was asked in the discussion, I think. See, the audience, I think you don't have to send the message. You can directly ask the questions. Okay, because we have very little time. Typing may take more time. You can ask. You can unmute your mics and you can ask.
I think he wanted to know why the larynx moves with deglutition.
This was asked in the discussion, I think.
Okay, now is the time for them
Yes,
to
sir.
ask, isn't it? The other examiners.
Yeah.
Yes, sir. Other examiners wanted to ask questions.
Yeah,
30 minutes
please
is
go
up.
ahead.
Please
Yeah.
go ahead. Please
Yeah.
go ahead.
Sir, you can give clarifications also, sir, if you want.
No, the clarification is that the larynx is attached to the hyoid. The hyoid moves with deglutition so that the larynx comes under the epiglottis while swallowing. So there is no aspiration. This is all done by the suprahyoid muscles and the infrahyoid muscles, moving the hyoid up. It's basically to prevent any aspiration, to move the larynx under the epiglottis. So that is why we say the thyroid will move with deglutition. But if we ask postgraduates, residents, why does the larynx move up? Very few people can answer. Or the physiological mechanisms of why we need to do this. I hope that answers your question. I don't know who is.
Yes, sir.
Yeah, okay. Go ahead with the other examiners can ask. We'll keep quiet.
Other examiners, can you please ask questions? Satish sir, Shipu sir.
Yeah, Chitra.
Hello? Yes. Yeah, please.
Okay,
You're
Chitra.
audible.
Okay. You were talking about ultrasound, indications for ultrasound. Just for making it clear for the audience, just tell me what are the indications at your level in your examination for pure ultrasound. I mean, beg your pardon, we were talking about FNAC earlier. Just tell me what are the indications for plain FNAC and ultrasound guided FNAC.
Sir, for small nodules, not very well palpable, and in multinodular goiter, and if the
You're
ultrasound
difficult to palpate nodule. Difficult to palpate nodule means posterior nodules. Posterior nodules difficult to access neck. For example, you have an obese neck. And then I thought you told something about cystic nodules. What about cystic nodules? Ultrasound guided FNAC. When it is more than when it is more than 50% cystic. And then again, the other indication is when you have a previous non-diagnostic FNAC. Already though you have run an FNAC, and then it turns out to be a non-diagnostic FNAC. Again, it is an indication. That means that when you answer the question, the indications for plain FNAC are easy to palpate nodules, solitary nodules, and there are no history of previous non-diagnostic FNAs. Such cases, possibly you'll do a diagnostic FNAs. Then second point is about your presentation, Chitra. I thought your presentation was good, but I think it was a bit patchy. In between, you answered very well, and for some basic questions, you don't answer. And that's the problem. In between, you answer very well. Some difficult question, for example, comet tail artifacts and all you answered. But possibly why larynx moves with deglutition is a basic question that you should answer. Especially second stage of deglutition, it moves up. And then you told you don't know. So that always gives you a negative impression on, makes a negative impression on the exam. But sometimes you answer very well. So that should not happen. Okay, that is a feedback I can give you on your presentation. Okay, thank you.
Hello. Hello, can you hear me?
Yes.
Yes, sir.
Hello.
In which all conditions you will get very hard thyroid swellings?
Malignancy, and especially anaplastic carcinoma.
You tell the common conditions first. As a postgraduate, at least you should tell three conditions where you will get very hard thyroid swellings. What is the commonest pathology you see clinically in thyroid?
Multinodular goiter.
So in which condition in multinodular goiter you will get hard thyroid swelling? Calcification. Any thyroiditis where you will get a hard feel?
Reduced thyroiditis.
So yes, these things should come very fast. Another thing you told about assessment of the vocal cord in any thyroid disease. Actually, what is the purpose? Just to clarify, you told you want to rule out malignancy. But medico-legally, what is the importance of assessing vocal cord?
Sometimes there is unilateral vocal cord palsy may be there, but we miss. But there is no voice change at all.
So what will happen?
To the
patient must have had a vocal cord palsy earlier, which must have compensated. And now you are not doing, after thyroidectomy, someone else is assessing the vocal cord. There is a vocal cord paralysis. They will sue you for making or you have made a complication, isn't it? I also felt you presented reasonably well, but I want to advise only one thing. Many times when the examiners are asking questions, you are keeping silent. It is an insult to the examiner. So you tell, I don't know, or you tell at least reciprocate that you heard the question. This is my humble suggestion. So they are repeatedly calling you whether you heard. Okay. So many questions they will have to ask. So you heard. If you don't know, you politely tell, I don't know, so that they can ask the next question, isn't it? So all the best.
Venugopal sir.
Hey, Chitra, you can say yes, no also. This is the misunderstanding that is going to happen.
I joined recently only, so I'm not heard completely. So some of the audience asked, what is the indication for radioiodine? Can you answer, Dr. Chitra?
In high risk cases, especially in case of extrathyroidal extension or N1 stage,
If meds, what will you do?
For local region involvement, distant metastasis.
Okay. Okay, I joined a little late only, so I can't comment you regarding your presentation. Okay. Anyway, as far as it is good.
Thank you.
Just one more point, Chitra. Just to add what Sadish was telling, what are the indications for laryngeal evaluation, indirect laryngoscopy in a thyroid patient with thyroid swelling? Patient is going for thyroid swelling. What are the indications?
For medical legal purpose.
Okay,
Mainly.
number one, medical legal. Number one. Then this is just your examination point of view. Number one. Number two.
To rule out the recurrent laryngeal nerve involvement.
Okay. Means what? Can it be a bit more clear? You want to rule out malignancy?
Yes.
Okay. So diagnose of malignancy. Diagnose of malignancy. Number two. Then. So just finish off. So ideally you should learn this. Okay. Number one is your medical legal. Number two is diagnosis of malignancy. Number three, staging of the. What about staging? If it is malignancy, what is the stage with the recurrent laryngoscopic palsy?
T4A.
That's it. Staging of the. You're right. It is T4A. Staging of the disease. T4A. Okay. Number four is again you had to rule out a pre-existing vocal cord palsy. It need not be malignancy. Already patient had vocal cord palsy, and again you have to rule out that. That's number four. And number five, you have to anticipate. Suppose there is a unilateral vocal cord palsy, you have to anticipate that this patient can get postoperative stridor. You have to anticipate that. Why? Because suppose the patient is going to undergo total thyroidectomy, the chances that the patient can develop postoperative stridor is high. So these are the 5 reasons you should always. This is just examination point of view. Okay, right.
Just to add one more point, you told there is no palpable thrill, isn't it?
Yes, sir.
What is thrill?
Due to increased vascularity in her hyperthyroidism.
No,
we can
what is
feel the pulse.
No.
Question.
No, question is different. What is thrill? And what is bruit?
Bruit, we heard the pulse, heard by auscultation, and thrill, we feel it.
So there is nothing called palpable thrill. Thrill is palpable. Okay. No need to tell palpable thrill and not audible bruit. Number two, you have done a thyroidectomy in this case or any other thyroid case, and after the surgery, you have seen that there is a vocal cord paralysis, unilateral. What will you do?
I will assess the patient in serial follow-up. Ideally, wait for 12 months record. Then I will assess serial follow-up. I will follow up the patient.
Did you listen to the question? You have done a surgery immediately after that, or the anesthetist during recovery phase is telling that there is in this case it was left side, isn't it? So there is a left vocal cord paralysis. What will you do?
Start on steroids.
Then there is no recovery.
Then I will wait and watch.
For how long?
For 12 months. For 6 months.
6 months. Or you will explore and look for any ligatures or the recurrent laryngeal nerve, any discontinuity. If there is a hematoma, first you will look for a hematoma. If there is a drain, and if it is not draining properly, and if there is a swelling, you will look for a hematoma. And if it is there, evacuate. If not, If you are not sure, 100% sure that you have traced it properly, it is always indicated to explore. If you are 100% sure, you can watch. Then one more thing, in a total thyroidectomy, you are 100% sure you have preserved both the recurrent laryngeal nerves. But post-operatively, patient develops stridor, a noisy breathing. What you will doubt and what will you do?
Immediately re-intubate the patient.
There is mild stridor. You won't look at the vocal cords?
Due to edema of vocal cords due to post-intubation.
No, this is just after surgery. You have done a total thyroidectomy. Will you assess the vocal cords first?
Yes.
You should assess the vocal cord.
Vocal cords.
Number one, any other condition that can mimic bilateral vocal cord paralysis and can produce mild stridor also.
Tapered trachea.
What other gland is, you told you will preserve some gland along while removing the thyroid?
Parathyroid.
So can you now correlate any other condition that can mimic?
Hypocalcemia.
So what will you do?
10 ml 10% calcium gluconate.
You will check serum
Over
calcium and parathormone, and if it is grossly reduced, you can give calcium and watch. Actually, nowadays, that is what I learned. Even if there is a bilateral vocal cord paralysis, don't intubate immediately. You can keep the patient in ICU and observe. Isn't it? Okay, other examiners can clarify on this if I am wrong.
Anyone else? Sadar sir?
Chitra, if this patient has a rapid increase in size of the gland, what all things he will suspect?
Hemorrhage into the polyp nodule.
Yes.
Or any anaphylaxis, carcinoma.
Malignant change.
Malignant
Yes.
change.
Infections can also a possibility. Infection. Okay. Okay.
We have 5 more minutes. Any more questions?
Dr. Chitra, I would like to ask one question. You have presented a thyroid case, and these days the PGs usually present cases like this because in the findings in the nose, after examining the anterior rhinoscopy, only you did the functional test in the nose. Is it correct, or is it the other way around? You should do the functional test first and then the anterior rhinoscopy. And the other professors can also correct me if I am wrong.
Yes, madam. First course bachelor test.
Because once you put the instrument, in a patient with an allergic nose, the findings will change.
Okay.
Nambudiri sir? Any more questions?
If no more questions, I think we can wind up. Sreekuar sir wants to go to ICU for some reason. We can relieve him.
Okay. Then shall we wind up, sir?
Any more questions? Hey, oh yeah. Chitra boy.
Shall we wind up, so then?
Can I tell a hi to Dr. Suresh Pillai?
Hi, Satish.
Hi.
Yeah,
How are
yeah, I
you?
didn't know you were listening.
Yeah, no, I was listening. I
Yeah.
learned something, certain points from you.
Oh, thank you. Thank you.
Thank
We
you.
should meet up when I come to Trivandrum.
Yeah.
Okay.
So, sir, Suresh sir and Naveen sir and all the others who actively participated, I think I have to thank all of you.
Yeah, thank you so much
I
for
think
inviting us.
we can release Sreekumar sir.
Okay.
Yeah. Thank you.
Okay.
Thank you very much.
Thank
very
you.
much.
Right, right.
Can we leave the
Suresh
meeting
sir?
then? Yeah.
Yeah.
Suresh sir
Yeah.
and Dr. Navneet, thank you. Thank you
Ishan,
very much.
thank you.
Ishan, hi. Hi.
Thank you, Ishan.
Thank you
Yeah,
very
yeah.
much.
Yeah.
Thank you. Thank
Good
you.
night. Good night.
Okay, bye. Take care, everyone. Bye.
Thank you,
Chitra
sir.
would be the most happy person.
Anuraj, hello.
Yes, sir. Yes, sir.
What about closing it?
Yes, sir. Yes, sir. So we have come to the end of another enlightening session of Fluent. I would like to thank Dr. Suresh Pillai, Dr. Navneet Kumar, Dr. Sreekuar Pillai, and Dr. Ramesh Kumar for sparing their valuable time for enhancing our knowledge. Special congrats to Dr. Chitra for doing a commendable job with the presentation. Thanks to the Solaris division of Sun Pharma for providing the platform and all the necessary technical support. And thanks to all the people in the audience for participating in the event, and please do continue your valuable support. We are winding up for now. Fluent will continue next month with a new case. Good night.
Good night.
Thank you, sir. Thank you.
Thank you.